We continue with the impressions in complete denture. The special tray is constructed, it is seated inside the patient's mouth and checked for the fit and extensions of the custom tray. If there is any modification which is required, either trim it or add the material so that there is proper extensions of the custom tray with adequate frenal notch which is provided. Same fashion it is done for the mandibular arch. Please ensure that the extensions are 2 mm short of sulcus on all the sides, labial, buccal and lingual. The tissue stops. Tissue stops help to prevent seating of the tray too much superior or posterior. It helps to stabilize the impression trays and helps us in obtaining uniform thickness of the material. Tissue stops are placed in the molar and cuspid regions. Starting with border molding, low fusing compound is used for border molding for segmental peripheral tracing. You start with the anterior region, proceed placed inside the patient's mouth. Either the patient can ask to do functional movements or the operator can pull the lip outward, downwards or inwards. Now once the anterior segment is recorded, then proceed to the right hand side distal borders and mold the region. In similar fashion, proceed on to the left hand side distal area. Once this is recorded, move on to recording of the posterior palatal seal area. Now either the patient can do functional movements or the doctor can pull out the cheek outward, downwards and inwards. Now recording the posterior palatal seal area as how it is shown here, that area is the one which helps in retention of the maxillary denture. So the patient has to put his head down at that 30 degrees and then the patient is asked to do Valsalva maneuver and the patient is asked to say ha in a short exaggerated manner for recording the anterior vibrating line. When the patient is asked to say ha in an unexaggerated manner, it can be used to record the posterior vibrating line. Use T-burnisher for the aid of identifying the hamular notch and recording the PPS. Similar fashion for mandibular border molding, either the doctor can pull out the lips and cheek outward, upward and inwards, or the patient can be asked to do all possible lip and cheek movements and then tongue movements by asking the patient to protrude the tongue and then ask the patient to retrude the tongue and ask the patient to put his tongue in the anterior part of the palate, posterior part of the palate, as well as touch the tongue on the opposite side cheeks. Now once this is done and the mandibular border molding is completed, you can proceed with secondary impression making. Previously we saw how border molding was done in a segment wise fashion. In contrast, border molding can also be done in a single step with the help of polyether material or with the help of putty material. Now when we do it in a single step fashion, the doctor has to be really experienced to record all the details properly, because if there is any corrections with these elastomers, it cannot be corrected, and if there are any imperfections, it has to be discarded and remade again. Unlike with low fusing compound, which is a reversible material, if there is any corrections which are needed, it can be done when low fusing compound is used as border molding material. In low fusing compound, the advantages are, one is corrections can be made, the other one is when it has contacted the tissues, it looks matte finish. When it has a glossy finish, it indicates that it has not contacted the tissues. So ultimately the border molded area should look like this: round, rolled and continuous borders, irrespective of whether it was done in a segmental fashion or a single step manner. So before final impression making, we ensure that we remove the relief wax, spacer wax, and ensure that the tissue stops in directly contacting the tissues, and then the border mold, we should not break the border molding material. Apply adhesives as elastomers are going to be used for final impression material, and then apply Vaseline to protect that if ZOE is going to be used, so that the material does not stick onto the circumoral area, and then instruct the patient about the setting time of the material, and then coming on to the material part of it, mix the material, load the material onto the tray, seat it and hold it until the impression material sits inside the patient's mouth. Once you remove, this is the picture showing how the impression materials are loaded onto the border molded custom tray and impressions are recorded. Now coming on to the test for retention, for maxillary, outward pressure is applied in the incisor region, or upward pressure can be applied in the premolar region, or you can pull the upper lip downwards. Now all these can be used for testing the retention for the upper arch. Now for mandibular, ask the patient to protrude the tongue or move the tongue in lateral fashion, or roll the tongue back to touch the palate, open the mouth, exert vertical pull on the handle and apply forward pressure on distal aspect of the handle. Now coming on to the selection of impression technique is based on the clinical findings, experience of the dentist, availability of the materials and patient related factors as existence of undercuts, because materials like plaster or impression ZOE impression paste cannot be used if there are undercuts because they chip off and they are rigid materials. Instead you can use elastomers, which are elastic material and do not chip or break while removing the impressions from the undercuts, and also identify whether the patient is an old denture wearer. Now if it's an impression compound, as I told you before, it can be easily corrected, it can be border molded, it can be used as an impression tray, it can be it's a viscous material, can be used for recording primary impressions. If it is an alginate, the material is elastic, it can be used for recording primary impressions. It can be used in cases where there are tissues are inflamed, or in highly resorbed ridge cases. And this material, but the limitations are it is not dimensionally stable and there should be perforations in the tray for mechanical retention of this material. Elastomeric impression materials are the best because they are elastic, they record fine details, they are hydrophobic, but recently available materials are made hydrophilic by addition of surfactants. Adhesive is required, it is available in different consistencies, it's dimensionally stable, but only limitation is it is quite expensive and requires adequate handling of the material. ZOE impression paste is rigid and elastic. It adheres to the tray, flows readily, can be used for making wash impressions, but the limitations are it can have a burning sensation or tissue irritation. It is a rigid material, cannot be applied in areas of undercuts. It can flake or break during trimming. Impression plaster is again employed when with minimal impression techniques. When there is going to be any flabby tissue or inflamed tissue, it can record with minimal amount of pressure. It is used for making wash impressions, but the limitations are again it is rigid, it can break or chip when used in undercut areas, and it can also have a potential to expand and requires separating medium, because if you do not apply, it will get adhered to the cast material. Tissue conditioners, on the other hand, can also be used for impression making with functional impression techniques, but it is relatively expensive. Waxes. Under waxes, you have mouth temperature waxes, which are Iowa wax, Adaptol wax, HL physiologic paste, and corrector wax number 4, which are used for recording the posterior palatal seal area. But these wax, again, the doctor has to have adequate skill and knowledge to use these mouth temperature waxes. When the tissues are inflamed and flabby, as how it is shown here, we use window technique and either use light body or impression plaster for recording the impressions.